Welcome. On behalf of the International College of Dentists, the preeminent international honor society for dentists, founded 100 years ago to disseminate dental scientific knowledge worldwide. My name is Christine Benoit, and I am the moderator of today's webinar entitled Confronting COVID-19. Our panelists are ICD fellows who are experts in dental health and safety. We thank them for generously sharing their expertise with us today. They will speak for approximately 50 minutes, and we will follow with questions and answers. To ask a question, simply type in the Q&A box at the bottom of your Zoom window and click send after you've written your question. It will be forwarded to me and we'll address them at the end of the program. It's as easy as that. So this webinar is part of a new college global communications initiative called ICD Online. The members of the team that organized this for us are working behind the scenes now to facilitate and help us monitor today's webinar. Those folks are Dov Sidney, the ICD editor, and he is Director of Communications, Joe Keneally, the Secretary General Designate, Jack Hinterman, the Secretary General, and Chelsea Seagrin, our College Operations Manager. We thank them so much. They're behind the scenes, but they're really not. They're working and helping us all the way through. They're wonderful. So our first presenter is Dr. Raghu Putaya. Dr. Putaya holds a Bachelor of Dental Science degree and a Master's in Public Health. He is the current Scientific Director for the ICD's Dental Safety Program. He's a Johnson & Johnson's Fellow in Infectious Disease Prevention in Dentistry. Dr. Putaya's topic is a bird's eye view of COVID today and after. Dr. Putaya.
Thank you. Good morning, everybody. Good morning, fellows. As you know, my topic is a bird's eye view of COVID today and after. It takes about a few days to develop a bird's eye view, and it takes about 2 hours to present it. I'll do my best in the next 8 minutes or so. So epidemics, emerging diseases are not uncommon. If you go back to 429 BC to 427 BC, there was the plague of Athens. And during my fellowship, I came across HIV and AIDS. I came across SARS. I came across MERS. I came across Zika, Ebola, measles, and COVID. I applied it a lot of times within my institution as a professor. And I also lectured to multiple groups. Now, if you have a thought about a bird's eye view, there are so many different aspects you got to think about an epidemic, especially one we don't know. There are many thousands of experts today, but it's very difficult. There are multiple fields that fill in the gaps in understanding the epidemic. Okay, and it takes a 2020 vision about a year or two later to understand what our policies were, where we began, and where we ended. And sometimes we have to retract our statements and papers and publications. If you expand the bird's eye view, these are the topics every single person practicing dentistry should understand. And it keeps changing. Okay. Now, let's talk a little bit about the disease. There are many types of coronaviruses. There are about 7. Today's is the latest. It's SARS-CoV-2. It is actually similar to the SARS we saw during 2002, 2003. The sources are from multiple, mammals. Okay, there are many types. The transmission as of yesterday or day before yesterday, has been from animals to humans and to animals, cats in New York. There are clinical features which keep changing. We started off with 4 symptoms, and now we are at 9 symptoms. On the epidemiology, our sources, or my sources, are primarily the CIDRAP at University of Minnesota. They are epidemiologists, they are mathematical modeling experts, mathematicians, medical doctors, and so on. Then comes, the map on a day-to-day basis, tracking it. It's Johns Hopkins. Then there's CDC that puts out every day or every week updates the screen. So let's talk a little bit about public health measures. These are not in the control of dentists. It is in the control of a public health law, the government, the organizing bodies, the governing bodies in the practice of dentistry. All of them get together and then they pass the laws and rules, okay, based on many other things. Now, when it comes to dentistry, what we have done is we pushed dental infection control or safety to the, to a back burner during non-COVID or non-epidemic times. But all of a sudden we start scurrying around, trying to find materials, equipment, prioritization, and mandates we have to follow. But do we have a comprehensive curriculum for basics? Yes, we do. But do we follow it? Maybe not. Okay. The training of educators and fellows are very important, for the future. And I think ICD should take the stand in this and become the future educators in this field. Now, dentistry. We are at the top 10% risk of all occupational codes because we don't work miles away or feet away from a patient. We are within 1 foot radius of a patient's mouth, and we create aerosols, bioaerosols, splash and spatter. Some of the gaps I've seen in the public health measures are explaining or defining what is a contact, whether contact is an important item. Next comes the exposure, and then next comes the post-exposure protocols of either quarantine or so on. We could have random exposures, occupational exposures. Now, there are many flow charts that are available by experts in various fields, which we need to find, use, and monitor. Now, we have screening tests and we have diagnostic tests. We don't have contact tracing as yet, as other countries have already followed because they had the infection earlier as well. We do not know whether there's going to be a protective stage after infection, or are we going to become carriers? We don't know the anamnestic response of this virus as yet. It's too early to even determine. When you open the dental clinics during COVID, for some reason, such as emergencies, urgent and emergent care only, you have to follow your local guidelines. You have to communicate. Communicate with your patients, with your staff, as to when to come into the clinic, and only come into the clinic if they are feeling good. If you're sick, or if you're at risk, or you have somebody at risk, stay at home. Let somebody else take the slack. Patient flow. Control the patient flow. Don't let a whole bunch of people come in. One at a time, restrict entry. And then if you find out a patient is sick, refer them, just as we did in TB. If they are a large entity like an institution, you could have multiple small dental teams, and they can work in a cascade method. Then you have to also think about when the patient leaves your facility. Since COVID does not have a very definite feature of feeling sick all the time, they could be shedding viruses when you've already treated them. So if they fall sick, they have to call back and let you know when they fell sick. So you can either quarantine or get tested. Self-monitoring. Before you come in, Make sure you're okay. Check your temperature. Make sure you're not feeling sick. Now, work practice controls. Use more hand washing. It's the simplest thing. After the advent of using gloves during HIV era, most people stopped washing their hands. I mean, stopped. Yeah, you wash your hands with a chlorhexidine gluconate, 2% or 4%, or an iodophor iodine-based soap, which is a scrub. Just using a gel in the absence of a hand wash, alcohol gel, is not of any great relevance to me. Use a hand wipe with alcohol or any other chemical germicide. It is much better than just applying alcohol on dirty hands. Okay, those are some of the things, Now, my issue when I've seen this, I've seen COVID, and during my fellowship, I used to go see patients, infectious disease patients during the grand rounds. And I had to go see AIDS patients, full-blown AIDS with TB. And later we got to know it was multi-drug resistant tuberculosis. I used to use these P100 kind of masks then. Okay, I never used a P95. I had multiple sets of those. In the morning session, I used to go see at least about 5 or 6 kinds of patients. I had to take them off after seeing the patient, decontaminate it, use another one, go to the next patient, decontaminate it. The thing with the P100 and P95, or N95 is P100s have a much better facial seal, and they have disposable filters you can dispose of at the end of the day. The P95s, although they are available to some extent, they really do not have a face fit. Look at the latest paper put out by CIDRAB and look at what Amy also has said. Now, there are many germicides of choice, but go to the highest level of germicide use as a surface disinfectant. Try to use something which is a chlorine compound, a peroxide, or you can use a phenolic at best. Going to the lowest level of low-level disinfectants, such as quaternary ammonia compounds, are not going to be helping you. Everybody, when COVID happens, they run. The MBAs make the company move to get a clearance on COVID kill. No, it is not that. So an intermediate level disinfectant should have a TB kill. It should have a hospital disinfectant claim of killing the 3 marker organisms, a virus kill claim of both hydrophilic and lipophilic virus. COVID is a weak virus to kill. If you change the pH, you can bust the coating of the virus and denature it. It should have a fungi kill, and try and find a disinfectant that can also be used in your dental water lines. So these are some of the items available. Now, the other aspect is controlling the air quality within your clinic. There are 2 different classes. One are air scrubbers. Air scrubbers can be centralized, or they could be individual units. They have a HEPA filter, UVC, or ultraviolet light C, with at least about a 260 nanometer wavelength. They have 4+ air exchanges and less than 50 decibels. That means they're less noise, and they could be from a large to a small capacity. The next level are the not air scrubbers, but they do not have UVC, but they have a HEPA filter. Those have been traditionally found good enough. They could be centralized, they could be individual portable units, and they have a moderate capacity. For dentistry, I think the second one works as good. When you want to go back, now all the states are opening up within the US, and in many countries, they're again trying to get back into the business aspects of dentistry in caring for the patients as well. Go slow for the first 4 weeks and slowly step up. Don't just blast in. Always be ready to use additional precautions. Make product sourcing available. It should be local and better. Mandate continuing dental education. And choose your educators. It should not be an industry sponsored, I feel, because I have been an educator all my life and I've dealt with industry in both research and development. I've never done public speaking for industries, but the local person should not be paid by an industry to come and sell products. It should be subject oriented. Okay. Thank you so much.
Thank you so much, Dr. Putaya. That was a wonderful presentation. I'd like to remind our viewers that they can send us questions to our Zoom window at the bottom of your screen and hit send. We look forward to hearing from you. We would also remind you that if you've come in a little bit later, that's fine. You can watch these presentations later. We'll have it on the ICD.org website, and you can share it with your colleagues as well. Our next presenter is Dr. Scotty Balding. Dr. Balding is an oral and maxillofacial surgeon on the faculty at St. Joseph's Medical Center in Paterson, New Jersey. Dr. Balding is also the director of airway in TMJ department at the hospital. Dr. Balding is in private practice in Arkansas and in Florida. We welcome Dr. Balding to speak about sterile techniques.
Thank you, Christine. It's an honor to be here with this distinguished panel and speaking to my colleagues all over the world. As an oral maxillofacial surgeon, my charge with my presentation today is to talk a little bit about what we should be doing in terms of maybe modifying our thoughts as dentists from a sterile technique. And one of the things I want to share with the organization as a whole is that this is a serious virus. I mean, obviously, you know, I was visiting with a friend over the weekend, and I mean, there's not anyone in the world that this has not impacted. Think about it. Every single thing, there's not one single dentist in the world that this hasn't impacted or should have impacted. And so what we need to understand is how this virus works. And I was visiting with one of our national and international leaders of the American Academy of Otolaryngology over the weekend and talking to him about presenting to this group. And, you know, the virus is very strange. We're seeing significant injuries to, you know, not only people of high risk, but we're also seeing some individuals that are actually getting the infection even with no high risk. For example, about 3 weeks ago, unfortunately, we lost one of our oral and maxillofacial surgery residents, and many of you may have heard about. He was 37 years old, double degree, about to finish his program, and 3 children, unfortunately. He apparently had treated a COVID patient about 2 weeks prior to him passing. What we believe is happening is the virus shedding that occurs. This virus is propagating primarily in the oral cavity and the nasopharyngeal region. And this area is very significant in relating to this. Apparently, the amount of infection you get, if you get one viral shed, your body then can attack that shedding with its normal inflammatory process. And if you're at a low risk patient, then your body will get ahead of that. However, if you're working in an area where you get a large viral load of this particular virus, then your body can get behind. And if you're a younger individual, then you may not have the immune system to respond to it. And that's where we're seeing this exacerbated immune response that's even attacking endothelial cells, and we're getting thrombi that are creating and causing strokes in these young individuals. What does that mean for us? What we're seeing on the front lines throughout the world, we saw this in Wuhan, we saw this in Iran apparently, and Italy, and I think we've seen it to some degree in Seattle and New York, is the top providers that we were seeing that were getting not necessarily dying from it, but getting sick, but getting really sick were the otolaryngologists. So the American Academy of Otolaryngology in the United States has stopped all use of rotary instruments and all use of any aerosolization, including suction, on non-tested patients up until this point. So if the patient does test negative, then they will resume sinus surgery, et cetera, whatever they're doing surgically. The colleague that I visited with over the weekend, a very prominent otolaryngologist in the United States, said his warning to the dental community is that he thinks that the dentists are at the highest risk in the entire healthcare sector because of the amount of potential viral load that we get. So it's not necessarily you as a provider as well, but also potentially your staff and the other patients in the area. So one of the concerns I think we need to talk about is open bays in dental offices, and how do we get closed bays? How do we isolate aerosolization? I know there's some questions about that, and I'm not the expert on those areas, and hopefully some of the panelists are. But it's important to understand that we've got to start understanding that what we do, and maybe what we are evolving into, is we are surgeons. We're all operating in a very important area of the body. It's where all the virus is usually transmitted. If you get this disease, it's coming either through your mouth or nose, most likely, maybe your eyes. So we can't we've got to protect ourselves and our patients, but we've also got to protect our environment so that we're not spreading this virus or other diseases throughout our practices. So how do we do that? Well, one of the things that we've done, I'm on staff at St. Joseph's in New Jersey, and we just fast-tracked an IRB. Dr. Pataya did a great job presenting some of the things that are associated with how we prevent this. But one of the things that we thought about was, how do we decrease this viral load in the oral cavity? One of the effective agents apparently against this virus, or the coronavirus, we do not know if it's effective against COVID-19 yet, we're testing it, is iodine. And so we're using a molecular iodine, not a compounded iodine, and it's an iodine mouth rinse. We're using it as a nasal spray, and we're also using it as a hand rinse. Our hospital is has a very high COVID population right now at this point. We have several in the ICU, on the floor, and in the emergency room. So we're providing the healthcare providers on the front lines with this product, this molecular iodine, and we're having them rinse with it 2 to 3 hours a day as they're treating patients. Whenever they get through treating a patient, they're also rinsing their hands and they're spraying their noses. We're seeing about a 10 to 15% infection rate of our providers in the hospital. And that's pretty much what we're seeing on the national average as well. So what we're hoping to do is cut down on the infections of our providers by using this product. In my practice, I'm also having my patients rinse with this iodine rinse before they even walk in the practice. And how do we know that that works? Well, in the OR, and many of you know this, in the operating room, we've used betadine prep, or iodine, providone iodine, for years as a prepping agent. And what I would encourage our industry to maybe start thinking about is start thinking about yourself as a surgeon. Now, not only do we prep the patient to prevent the patient from getting infected, but we're also trying to prep the patient with iodine to keep the room from getting infected and to spread that infection throughout the operating room and throughout the hospital. So one of the things that I hope to emphasize today would be, as you begin to go back in your practices, wherever you are in the world, be thinking about yourself as a surgeon. Think about what you're doing in terms of not only protecting yourself with the N95s or gowning or caps and shoe covers, et cetera, but think about what you're doing in the environment, and some of the things that Dr. Pataya talked about today would be good for your practice. We're covering everything. We do our head cover, the face shields, masks, full gowns, shoe covers, and then we're isolating barriers over everything in our ORs, including the foot pedals. So, and then we take those and throw them away and disinfect the rooms when we're through with it. So I hope that's been helpful today. And Christine, thank you for allowing me to participate.
Dr. Balding, I think all the viewers really appreciate the information you shared. Thank you so much. So our next presenter is Dr. Ho-Yil Chang over in Korea. Dr. Chang is a prosthodontist and implantologist, and he's vice president of the International College of Dentists. Dr. Chang's topic is giving the perspective of a practicing dentist in Korea. Dr. Chang?
Hi everyone, good evening. This is, it's 9:26, the late evening in Korea right now, and most of the people is early in the morning. So the topic I'm gonna present today is, it's running the usual dental practice under this kind of extremely unusual COVID-19 circumstances. I have the private practice in Seoul, Korea. And since Korea is one of those a few countries which don't lock down the dental clinic completely, I'm still treating the patient in my clinic every day on the regular basis. But as everyone knows, the dentist is the most risky occupation on the current situation threatened by the COVID-19 because of the clinic environment and the way we are working. We are exposed to the aerosol during the tooth preparation and mouth washing with the air water syringe and to the saliva droplet and even to the blood. Even though we are using N95 masks, still the pore size of the filter is much larger than the size of the virus. At the beginning of the COVID-19 strike, some of the Korean dentists closed their clinic for 2 weeks on their own decision, since we thought if we had survived 2 weeks during those incubation period, and we could have gone back to the normal life. But the situation got worse, and even though they opened the clinic back again, a large number of the former patients group don't visit those clinics anymore due to the rumor that the reason why those clinics were closed was that the dentists or the clinic workers of those clinics were infected by COVID-19. So it has been almost 3 months since we were actually affected by the COVID-19 in Korea, but there has been no complete lockdown so far. So of course the school are closed till now, and the people keep the social distance rule pretty well in Korea. Almost everyone is wearing outside home, and the masks outside home, and the government is tracking the moving route of the infected people and informed to the local people well. And this action actually contributed a large part to suppress the spread of the COVID-19 in Korea. But the problem is still, we don't know about the COVID-19 100%. And that virus can be infected through aerosol or direct or indirect contact of nose, mouth, and eyes. Sometimes that virus survives in the air up to several hours, and it even survives on the metal or plastic surfaces up to several days. And most of all, the incubation period of COVID-19 is more than 2 weeks, and those incubatory carriers can infect the others. Nevertheless, we open our clinic and have to treat the patient. So to survive, and we have to set up the best possible infection control rules and the protocols under each different situation all around the world. The first, we have to protect ourselves and the staff. And second, we have to protect our clients, the patients, against the possible cross-infection. And we have to protect our family members once we go back home. So I will show some tentative infection control protocol which I apply in my clinic and at home and in my home. The protocol is just tentative one, and as the nature of that the coronavirus is revealed more, and the social situation is changed, we have to modify and even have to set up a new protocol too. Fortunately, our occupation is familiar to use the masks every day, and before the COVID-19, we still had the protocol for infection control in the clinic. And now we added some more the patient screening courses and more protection gears and use more antiseptic chemicals. Let's see the short movie, the first short movie, please. Okay, we cover the metal surfaces which have frequent hand contact, such as the elevator button or door handles with copper-coated antiseptic film, and put the notice written, wear masks, check the body temperature on the reception desk, and wash your hands. Once anyone visits our clinic, including patient, their family, or just visitors, we check the body temperature and ask the symptoms such as fever, cough, or fatigue. And if any symptom is found, dismiss the patient right away and make another appointment on the phone after they are screened the COVID-19 infection at the screening center. If the patient is emergency situation or severe pain is involved, refer the patient to the University Dental Hospital. And after the patient passed the initial screening, ask the patient wash their hands in the powder room. And let's see the short movie, the number 2, please. And this is before the COVID-19. And then to protect ourselves and the patient, basically we wear a scrub or white coat, eyeglasses or goggles, and gloves when we work in the clinic without those the surgical the operations. And let's go to the movie number 3, please. Okay, this is after the COVID-19, and then overdose, and we wear a disposable surgical gown, and then wear a KF94 mask. It's something like the N95 mask, and over there, and dental mask with a clear face shield over it, and the surgical cap. And let's see the movie 4, please. And we also use the HEPA filtered air purifier corner by corner. We have total 8 air purifiers in my clinic, and then with a small amount ones, and then every corner we place that one. And let's go to the movie 5, please. And after the patient treatment, and we wipe up the unit chair and the floor with 2 kinds of the sterilization spray. The one is hypochlorous acid, and that is the one we used to use in the clinic before COVID-19. And we added one more the sprays, and this is the new one, and that's alkyl dimethyl benzyl ammonium chloride. And then this is the chemicals the government used to sterilize the COVID-19 infected area. And when we go back home from work and we have to protect our family against the COVID-19, possibly we carry in. So let's go to the movie 6. This is my home, and we use the closest bathroom from the entrance as a kind of tentative quarantine room. And from the entrance, the right side door is our outside the bathroom. And once I come back home, I stop by the quarantine bathroom and then throw the used mask away and take the outer off and leave it on the hanger. And then wash my hand first. And then wipe my cell phone with the alcohol swab. Then take all the clothes off and leave them on the hanger and go to the main bath and take a shower first. And after several hours, we put some clothes in the washing machine and do laundry, and also use the virus sterilization mode. This is the costume styler, and it has the virus killing mode, something like that. And this is the it tells the virus in Korean language. And then it used the steam and dry heat for the clothes for sterilization. And as a dentist who is still running the usual practice under these extremely unusual circumstances, nothing's 100% perfect so far. So we need more information about COVID-19 and have to set daily updating protocol for all the dental practitioners and the staffs in the world. Thank you.
Thank you so much, Dr. Tang. That was a fantastic and most interesting presentation. We commend you for all your work in keeping the safety of the patients in your city, Seoul. So our next presenter is Dr. Doug Risk. Dr. Risk is a retired Air Force dentist in private practice now in Southern Maryland. Dr. Risk is Vice Chair of the Board of Directors of the Organization for Safety, Asepsis, and Prevention. He is also a civilian Air Force consultant on patient safety and infection prevention. Dr. Risk's topic is using the current CDC, World Health Organization, and national guidelines and the way ahead to return to providing routine dental care and safely and confidently, focusing on infection prevention. Dr. Risk?
Thank you, Christine. I'd like to build on Dr. Balding's and Dr. Chang's presentations with a little bit about what the U.S. has found as some of the interim guidelines that have been developed through our national organizations, to include the ADA, which just brought out their new ADA toolkit yesterday. So I was spending a little bit of time going through that to see what's changed from the 1st of April, and we're going to talk a little bit about those recommendations. I'm going to go ahead and share my screen. Bear with me for just a minute while I get this to, oh my goodness, work, hopefully. Come on. Okay, so like I said, I'd like to frame this with a sort of understanding of a chart that I think gives us a little bit of opportunity to put our control measures into perspective. How do we safely do dental care, but then as well, how do we put our physical hazards and physical controls into a perspective that how well are we doing? There's been a lot of emphasis on PPE. You can see PPE is at the bottom of our inverted pyramid, and the social distancing and the emergency only care is more at the top of the pyramid. So it has a hierarchy of how we're controlling our exposures. So going through the pyramid, basically at the top of the screen, which is the most effective type of exposure control, starts with the elimination. This is where we've talked a little bit about testing. I want to talk about the ideal test. We saw in Korea and Dr. Chang's presentation that they're taking the temperature at the front desk, but wouldn't it be nice to have a screening tool that someone could spit in a little cup, you do a little dipstick, and find out if that patient is infected or not. That's where I think the biggest benefit to dentistry would be to find out if those patients that walk through your waiting room are actually carrying the virus and shedding the virus. So that's something that hopefully we would see in the not too distant future. This test doesn't exist yet, but that's kind of the type of elimination of exposure that we'd like. Those folks that are having emergencies, we could treat appropriately. We could defer those that are shedding the virus without generating any aerosols or even generating an immediate patient visit. So elimination of the exposure, we're doing that already with our screening questions. We're taking that information from patients. Are they sick? Are they feeling well? What's their international travel history over the last month or two, and trying to come up with their risk. So that's elimination, and that's really one of the better ways to control your risk of exposure. The CDC is still recommending that aerosols are not generated. So that's kind of throughout this entire controlling exposure presentation is sort of the elimination phase. How do we substitute in our hierarchy? With chemistry and with disinfectants, we substitute more toxic with less toxic. So that's what substitution is in the hierarchy of control. We can't really substitute sort of one patient for another, or a patient that's not infectious with, or that is infectious with a non-infectious patient, but we might be able to substitute treatments which would have less exposure to either the staff or the room or the patient. So we could end up substituting a non-invasive procedure for an invasive procedure, maybe fewer teeth involved, maybe instead of doing a full mouth operative or restorative procedure, do quadrant dentistry, go back to quadrant dentistry, and that may be a way to improve our exposure control with substitution. Another way that we talk about reducing exposure is with engineering controls. We know that most of our restorative dentistry does generate aerosols, and the aerosols are going to be contaminated with saliva. They may have a little bit of blood in them and so forth like that. And we've been dealing with that forever and ever and ever. And just as we changed the way we approached that with surgical procedures and the AIDS change in dentistry, the 2003 dentistry guidelines that came out from the CDC in the US, many changes happened with that, and I think we're up against another opportunity to change as well. So we want to avoid our aerosols when we can. For the aerosol producing procedures, we're going to be looking at how to control the contamination of those aerosols. Isolation of the operative sites, bringing back the rubber dam in isolating teeth that we're going to work on may be a huge benefit to putting some of those aerosols out of the exposure zone. So if we were to use some kind of rinse to, you know, a lot of folks use pre-rinses now, Listerine or chlorhexidine or some kind of pre-rinse. There's no reason why we shouldn't continue to use that, but then add and rinse, maybe a pre-rinse that attacks just the virus, apply our rubber dam, isolate our operative field, check to see and make sure that we don't have any leaks and so forth. And then as we rinse off our rubber dam and rinse off our operative field, we may be able to also combine an iodine material like Dr. Balding was talking about doing those research items with, and perhaps even a peroxide rinse that would eliminate or reduce or kill a significant portion of the viruses that are in our operative field outside and in the exposure prone area of our rubber dam. And then we know that the pre-rinses are no longer part of the ADA interim guidance as of yesterday, but they were at the beginning of the month. Administrative controls, we've already talked a lot about that. I think the education that Dr. Pataya was talking about is going to involve a lot more of the transmission-based precautions, which generally have not been too much of a concern in dentistry. The droplet, the airborne, and the contact precautions. We know a lot about standard precautions, and that increase of education is going to be huge for the practice of dentistry moving forward. All of the pre-screenings, all of the enhanced disinfection of common areas, as well as the operatory, is going to play a big role in the administration, the new protocols and the new procedures that we do. Dr. Chang mentioned, and Korea has done a great job on finding those disinfectants that are effective and putting those processes in place very well. And then finally, PPE is our least effective, mostly because the PPE is not perfect. There are opportunities to not don PPE properly or correctly. There's opportunities for leaks. There are shortages with PPE, and that's the most difficult opportunity to stop the virus. So as we go down the pyramid, PPE is our what we're focusing on, but it tends to be the least effective way to protect both the staff and additional patients. We've got to look at fit testing on our N95s if we choose the N95 route. There are 4 big portions of that program: program administration, medical evaluation, fit testing, and training. And those really do need to be emphasized when we go to something like an N95 mask. I tried to do this in a relative short period of time. I hope I did okay. And thank you very much for all that attention. I'm going to try and unshare my screen now. There we go.
Hey, Dr. Riss, that was fantastic. And thanks for sharing this very current information with all of our viewers. It was fantastic. Our next presenter is Dr. Andres Pinto. Dr. Pinto is a professor of oral medicine, and he's department chair, and he's assistant dean at the Case Western Reserve University School of Dental Medicine. Dr. Pinto is board certified in oral medicine. He is also the president-elect of the American Academy of Oral Medicine. Dr. Pinto's topic is dental school education in the humane aspect of COVID infection. Dr. Pinto.
Thank you, Christine. It's a pleasure to be here and present this topic. I think the first question that we should look at is how this is impacting how we teach our workforce of the future. And I will share my screen as well. And these are, as everybody knows, uncharted times. We're definitely not expecting anything like this to happen, at least in my lifetime. And we had to pivot and really think about how we deliver content to our students and as well as to our residents. You know, we had to redefine what we consider clinical competency in the face of social distancing in dentistry, which is almost, you know, there's really no possibility of avoiding social dentistry in clinical care. We had to think how our competency exams were delivered, how are we doing live patient testing with our patients, if we are still doing that, and quite frankly, how licensure will be processed, not only here, but globally. I've been talking to all my colleagues in academia across the world, and we face similar issues. You know, are we transitioning into distance learning, which it does lend itself to adequate teaching for certain topics, mostly content-based topics. However, as we all know, clinical teaching, simulation teaching, it's a major hurdle. Some of this distance learning, you know, 6 months ago, I was very naive to telemedicine concepts. I was very naive to distance learning, except very small platforms. And we had to get a crash course, basically in 3 or 4 weeks. We had to transition all our content delivery to online. And again, this is happening, I'm sure, all across globally. And think about how we're going to deliver this content and deliver both synchronous and asynchronous content to our students. So how does the oral care clinician dentist look in 2020? Well, I can tell you it doesn't look like the last year's clinician. We have many challenges, but we also see this as an opportunity, and a chance to rethink and reinvent ourselves, how we train our students. Challenges have been exposed already by my colleagues who have spoken before. Of course, we're in the highest tier of risk as far as transmission as of today, based on what we know. We are also being challenged for patient flow. For example, design of clinics where we could have capacity for 60 or 50 people to be waiting in the waiting room. Well, of course, that's not going to happen anymore. And we'll have to think about how do we do this patient flow. It's basically an ideal process, if you will, or workflow case scenario where we are challenged with maintaining adequate patient intake and at the same time make sure we protect both patients and students. How do we screen for the disease? I think we've spoken about that, and my colleagues have done a great job in doing that. However, as many of you know, asymptomatic carriers, those are the big, kind of elephant in the room, even though they're not febrile, no symptoms, and the symptoms keep growing, right? As of last 48 hours, the list of symptoms keeps growing to include very non-specific muscle pain and other things that, at least in my clinical practice, 70% of the people may be complaining of that. So it adds a component of fear to learning to our students. You can imagine being a year 2 dental student or year 3, depending on what type of curriculum you're doing, if it's a 5 or 4 year, depending where you are in the world. And knowing that in 2 months you're embarking in clinical care and then this happens. So certainly it's hard enough to learn the actual technical parts of dentistry and then be faced with this challenge. However, we think this provides a time frame where we can really focus on what's being talked about in asepsia and looking at improving our processes. Is almost like talking about a checklist, if you will, for those of you who read Atul Gawande. Doing a checklist of what we need to do, and as Dr. Balding very elegantly explained before, we are all surgeons, and dentistry is a surgical specialty, and we need to have our students understand that they are going to be held to that standard, and it's a decision of health, basically. We are thinking also looking at portfolios with our accreditation bodies across the world. Of course, clinical licensing is being challenged, and rightfully so. And we have to think about other ways we can imprint our seal of quality to our students when they graduate. We're basically sending these fledgling dentists into the community with a seal of approval saying that they are competent to be practicing dentists in the world. And we're basically losing one of the main tools that we had, which was live patient practice as a clinical scenario. We already spoke about the barriers and suction issues, and definitely this will have us rethink as a profession into the value of prevention and hopefully leverage this arm or this strength into compensation paradigms and how prevention is now compensated in dentistry, which is challenging, although we could imitate some of the global or package compensations being done in healthcare, where you're compensated by keeping the patient out of your chair in good health and without complications. So to engage our learners, our students, with our delivery of online content, I've been talking to my faculty and my colleagues, and we've delivered at least 200 hours of distant learning content in the last 2 weeks. And how do you know the student's really there? So those who put their cameras there, of course, you can see them. But if you're lecturing to 80 students, 90 students, 120 students, you will eventually have to admit that some of them will not even be present. They may be in, but they may not be present. So we need to relearn as academicians how to engage these students, how to make them think that we're very relevant still in healthcare, not only in oral healthcare, but this is an opportunity for us to make our imprint in science. Testing, salivary testing for COVID. How can that be a point of care delivery? How can we change or challenge the current care paradigms of, just to give an example, having a periodontal prophylaxis every 2-3 times a year? I can probably imagine, at least in the next 6 months, probably half of patients or more will not want to have that done, if not more. This represents an opportunity where we can strive and pivot. We can help create new technology, teaching tools, local laboratories, dental laboratories in the area where I live. They're producing swabs to do the samples. They have actually the most larger capacity to produce 3D printed swabs to do intranasal testing for the virus. And they jumped on, and the government contracted with them because they had the capacity to do it. Definitely, they will enhance our opportunity to provide small group instruction in a creative way. So you have distance learning. Small group instruction is ideal for distance learning. We can create blended programs as we fear this is not going to go away until we have a vaccine. So we have these different waves and cycles of disease that are going to probably cause disruption in education, but we can actually prepare blended programs where we can switch between platforms and in-person, face-to-face contact. And that way, we can assure first that we're teaching what we're supposed to be teaching. Second, that students are comfortable, that they're not having to break every 2, 5, 6 months or a month and do complete isolation. Now I wanted to talk briefly, a couple of slides about the oral health impact. And as we have heard all across, emergency care, what does that mean? What is emergency defined? And as you know, emergencies in the beginning of our epidemic phase, emergencies had one meaning, and then eventually they were well defined by different groups. However, this will probably impact access to care of people who either are affected by determinants of health. We know there's a major, we don't know why, but there's a major preponderance of males who are affected now from those who are hospitalized. Certainly, we know the issue about age, although as was presented before, age may be a little bit of a false indicator because young people also get infected. We certainly know that those of us who are medically compromised, we are at a higher risk for sure. We definitely, even as minimum as having hypertension. What does that mean? There may be some physiologic backing to this with ACE inhibitors and whatnot, and lung function. We don't know how the immune system reacts to this. At least at this point, we're not very comfortable. We know some of us react overexpressing our inflammation profile and killing our lung tissue, by the way. So there is a lot of unknowns, of course, that actually are going to affect, unfortunately, those who have the most severe disease. Those have more disparities, being access to care, not only financial, educational, geographic disparities. And unfortunately, as we have seen in many countries, the access to emergency rooms for conditions that require emergency room care, like cardiac disease, MIs, other GI emergencies, have been decreased because of the fear of contracting the virus. So people are delaying urgent care, not only oral, but also medical urgent care because of fear. We also have a technology divide. I was talking yesterday with some of my colleagues in South America, and there's a different profile in terms of the availability of critical care access there. Availability of PPE, we are getting ready and gearing up to open our clinical offices and our clinical student teaching in the next week or two. However, we did, because of what happened, we had to donate a lot of our PPE to our colleagues in medicine. So until we get a really streamlined availability of PPE that is available for a clinic of 300 students. I'm sure we're going to have to start in a very slow fashion. Certainly gauge the infection risk. Again, are we going to have areas of donning and dropping our PPE? We probably should. However, we're not going to be, business as usual is not going to happen. We're going to have to create areas where clothing is going to have to be kept pre and post procedure. How is this going to be sterilized? Depends also on the healthcare design system that we have across the world. Some are different to others, and that will represent opportunity to recreate healthcare systems in areas where there's some isolations, where there is no access to oral care that is very easy to do. How oral emergencies or trauma is going to be managed, where the next oral maxillofacial surgeon is probably 20, 30 miles away, I'm sorry. And finally, we are part of healthcare teams, and this represents an opportunity for us to really impact our role, besides guarding oral health for our patients, making ourselves relevant in healthcare systems, in screening, for example. As we all know, population screening is the gold intervention here to know where the cases are, to follow cases and isolate them. And that can be done, and we are 200,000, millions of dentists in the world. We probably can help with this screening, and it will protect us, it will protect the public, and it will protect our patients. So that's what I had. Thank you very much.
Dr. Pinto, thank you so much. That was fabulous. I do know there are many people in education right now watching, several in Southeast Asia, several in the US, and they're going to be able to share this information with their faculty at their schools, and I enjoyed it personally myself. Thank you so much.
Thank you much, Christine.
That was very good. So we have many questions coming in, and I do want to tell the folks that have submitted them that we will ask our panelists to answer them. We will go through several at the end of Dr. Tollner's next presentation, but if we don't get to your particular question, we will add it, and it will be on the ICD website, because it will certainly be valuable to other people if you submit that question. So our final presenter is Dr. John Tollner. Dr. Tollner chairs the International College of Dentists Get Smart About Antibiotics program in partnership with the US CDC's Be Antibiotics Aware. Dr. Tollner was Chief of Dental Services at the Veterans Administration Medical Center in Richmond, Virginia. He was also an educator at the Virginia Commonwealth University School of Dentistry. Dr. Tollner has lectured nationally and internationally on infection control and bloodborne pathogens. Dr. Tollner will be describing the risk of antibiotic resistance and mutation as it pertains to COVID-19. Dr. Tollner?
Thank you, Christine. I appreciate that. And it's my pleasure to be here today. I've really enjoyed the presentations to this point. I've learned a lot, but also it gives you a greater appreciation for what we're dealing with COVID in dentistry. And it is a very difficult task. Again, I've been asked to cover two topics. One is near and dear to me since I have become involved in the antibiotic resistance issue with the International College of Dentists. I've personally learned a lot. I was a hospital dentist, and I spoke primarily about infection control and dental operatories, which was covered real well today, as well as universal precautions. Again, covered well so far. Got a few comments to make on that in bloodborne pathogens. But what was interesting is about 4 years ago, about 4.5 years ago now, I went to after an ICD conference, I got interested in infection, antibiotic resistance. And as such now, I've learned a tremendous amount that I didn't really know when I was talking about infection control and dentistry. Really in about 2002, when SARS became a big issue, from that point on, we've had to deal with some epidemics and pandemics. Right now, we're dealing with a very difficult pandemic, and I'd like to talk a little bit about our program on antibiotic resistance in the International College of Dentists, and then blend that into how this may affect the pandemic that we're dealing with COVID-19. Can you see my slides now? We're good to go. Basically, the International College of Dentists 4 years ago set up this program, which you can find online, and hopefully you've had a chance to see it. It's under the projects section. And basically what we did is were approved in January of 2016, which is an important date, to start this program and educate dentists in the ICD, and not only that, outside the ICD. Our primary role or vision for this was that the ICD fellows and all dentists need to educate their staff, patients, family, and even friends about the importance of this critical problem, namely antibiotic resistance or antimicrobial resistance, and how it affects worldwide, and how to promote everyone's responsibilities, our responsibilities as dentists, to our staff, to our patients, and really to our family and friends. And a lot of this has been covered already. So here we are 4.5 years down the pike. And initially, when this became an issue, we were dealing with data from 2013, which we found out in November of 2019 when the CDC put out a new United States report. And we'll talk about world in a moment, but United States report, that the numbers were grossly underestimated of how much antimicrobial resistance really did cause in terms of death and illnesses in our country. So this 2019 report came out and changed a number of factors for us.
Dr. Schuldner, your slides aren't showing us. We can't see the slides.
Okay, I'm sorry. I apologize. Here, let's try this. That work a little better? Slide sharing. Are we on now?
Oh, yes, here we go. Thank you.
Okay,
All set.
okay, great. And basically now we're at a point where in the United States alone, more than 2.8 million people have antibiotic resistance every year. That's a big number. Think about what we're dealing with COVID. And of those people, 35,000 die as a result of an antibiotic resistant infection. When you think about it, if we're looking at world numbers, it's even more impressive in the sense that by 2030, the antimicrobial resistance could force up as many as 24 million people into extreme poverty. Currently, there are 700,000 people that die each year worldwide. Those are the current estimates of drug resistance diseases, including 230,000 people who die from multi-drug resistant tuberculosis alone. So this affects a lot of things. And I'd like to make a point right now. Antibiotic resistance is really part of a subset, the set being antimicrobial resistance. And antimicrobial resistance really encompasses not only bacteria, but it incorporates viral infections, it incorporates fungal infections and protozoal infections. But the predominance of what we're dealing with in dentistry is in fact antibiotic resistance, although certainly some viral infections. And antifungals, for instance, there's a Candida auris right now, which is one of the big actors in terms of antifungal, antifungal or fungal infections affecting this. Okay, so what happens? So the World Health Organization current plan in terms of a global view here, they've established a global action plan for all countries. And I'd like to stop at this point and say, while our program started in January of 2016, in September of 2016, the UN General Assembly, this is the worldwide leaders meeting, in 2016, September, made a commitment to fighting antimicrobial resistance together, all the leaders. This was only the fourth time in history the UN had a topic that was discussed at the General Assembly amongst all the leaders, the others being HIV, non-communicable diseases, and Ebola. So it shows you where this ranks internationally, yet many times we don't hear a lot about it. You don't hear it like we've heard COVID, but the numbers are definitely there. So this is a worldwide problem. It's not a United States problem. It's not, a Southeast Asia problem. It's a world problem. And the World Health Organization has given it high priority. As a matter of fact, just to give you an idea, and I put this slide up so you can see, this happens to be for Southeast Asia, but the World Health Organization has these topics divided into sections if you go on their website, and you can get good information on antimicrobial resistance in different parts of the world. And I think it's a total of seven different areas that you can go into, whether it's the Americas or, what have you. So what are some of the key facts? Okay. We've already mentioned that antimicrobial resistance, and I'm using that term to include obviously antibiotic resistance, threatens the effective prevention and treatment of a range of infections caused by bacteria, parasites, viruses, and fungi. AMR is an increasingly serious threat to the global public health and requires action from all governments across all sectors in the society. With effective antibiotics, without the effect of antibiotics, the success of surgeries, including elective surgeries, all types of major surgeries, cancer, chemotherapy, and now COVID, and we'll talk about that in a moment, can be affected because antimicrobial resistance is the actual viruses or bacteria taking advantage of someone that's already in an immunocompromised state. And obviously we have that with COVID, and I'll talk about that again in a moment. This is to give you, it's a slide of a dashboard picture, just to give you an idea of COVID in the United States. Now we're kind of blending this into the COVID issue. Total confirmed cases, 2,962,915 is 2 days ago. Total deaths, 205,936. And of course, we're seeing that climb rapidly. The 35,000 deaths that I talked about in relation to antibiotic resistance was passed maybe a week ago in the United States, but up to that point, it was climbing rapidly and still is. So this is a big issue for us, and we have to, deal with it. Again, we started our program in January of 2016, and within a few months, the UN General Assembly addressed this. It's so bad. I want to mention one other group because there's probably an audience from Europe, a fairly broad audience, and there's something called the ECDC, which is the European Center for Disease Control and Prevention, that you should be aware of. And these websites you can delve into on your own in your own time. I want to make a comment. David Redfield, Dr. Redfield, who is the director of the Centers for Disease Control and Prevention in the United States of America, made a comment, and he said some time ago when they came out with this new guideline in November of 2019, that he stated, and I'm going to read it directly, quote, "Stop referring to a coming, it's already here. You and I are living in a time when some miracle drugs no longer perform miracles and families are being ripped apart by a microscopic enemy. The time for action is now. We can be part of the solution." Think of the date. This new product from CDC came out in November of 2019. We're now what, 5 months later, 6 months later, and look what we're dealing with COVID. It's gotten dramatic, and I think we need to say there's a very good possibility or matter of fact, I'm sure it's already happened, of antibacterial, I should say, antibiotic resistance or antimicrobial resistance being a large player in causes of deaths for people with COVID-19. I'm going to tie my presentation up. I do have a few comments I made, I thought of along the way here. One thing is hand washing ties both of these together, both COVID-19 and basic infection control. And I hope to think that dentists do set a standard here, but hand washing is critical. And as you probably know, soap alone, soap and water will break down the lipid coating on the COVID-19 virus, the COVID-2, and actually relatively easily destroy the virus if you do proper hand washing and do it regularly. So you have to not only do it, but do it regularly. Don't just have someone splash their hands with water. That won't work. But soap and water is a very good hand cleaner for this virus and in general dental infection controls. And the other thing I wanted to mention about PPE is masks. Masks are it's important that we understand the different kinds of masks. And when I was in a VA hospital situation when we first had HIV/AIDS in Hampton, Virginia, we were fit tested for N95 masks. And just so you realize that, number one, N95 masks really are very difficult, if not impossible, to function properly with facial hair. That's a big issue. Another issue is when they're fit tested, basically, they put a hood on us and we put the mask on, fit it to our face. This was a basic N95, not a respirator, and put a hood over us and sprayed saccharin in to check if we could smell the saccharin. So it's not just a matter of using a mask. You want to be sure you're fully protected in whatever kind of mask you use. And of course, we know basic procedure masks don't really filter the virus because it's so small. Another last comment I'd like to make is that read the two comments. One is read the directions. And this is hard for me to say as a male of the species, but you got to read directions, especially when it comes to disinfectants. There are many issues that people are confused or otherwise misunderstood about disinfectants. So please make sure that the folks you deal with read the directions and understand that not every Clorox wipe has Clorox in it. They do make Clorox wipes with Clorox, and not every surface disinfectant by any means is not an antiseptic skin disinfectant. So that's important. And another thing I wanted to mention is that change is difficult. Change is not something we adapt to readily. And I'll give you an example. I had someone working here yesterday and we were looking on something on the computer and I walked right over to, stood behind him and we did things. Maintaining the social distancing of 6 to 12 feet is not something we come upon easily. Most of us in the United States, at least, have shaken hands for so long. It's hard to break these habits, but it's something we have to really work on. And I can't stress that enough. It just doesn't come naturally to change habits. You really have to kind of think about it and have reminders, constant reminders. That's why in every bathroom in our house, we have soap, water, and alcohol gel. I have a little cartoon of hand washing, and I think that's a key thing that we need to stress for people. And with that, I'll say that's all I have for today. And thank you very much to everyone that's participating.
Dr. Tollner, thank you so much. That was a fantastic presentation, and for all the work you've done regarding antibiotic resistance with the college. That's been fantastic. We have time for 2 questions of our panelists. We have about 60 questions in, so what we plan to do is archive this seminar and have the panelists kindly share the answers with you. We hope to do that. So the first question is for Professor Pinto. Are there any oral manifestations of COVID-19 detected so far, Dr. Pinto?
To this point, no. To this point, no, we haven't seen any.
Okay, thank you. And Dr. Balding, we have a question of the percentage of the iodine.
The study that we're doing in New Jersey, it's 100 parts per million molecular iodine that we're using. And remember, this is a molecular iodine, which is not compounded iodine like betadine. So the rinse and the nasal spray is 100 parts per million.
Okay, thank you very much. ICD thanks all of you for viewing and our expert panelists for being with us today. The presentations were recorded and will be available to watch later in a few days at icd.org. Due to the evolving and ever-changing science and knowledge regarding COVID-19, it's necessary to follow your authorities in health ministries in your area with their guidelines. On behalf of the International College of Dentists, we wish you to be well, to be safe in these ever-challenging times. Thank you all.